name is Dr. Kamran Sheikh, and today we are talking about the uh, Korsakoff syndrome, which is a complication of Wernicke's encephalopathy. So, Wernicke's encephalopathy is the delirium part of the Wernicke-Korsakoff syndrome, while the cognitive impairment part is the it is called the Korsakoff syndrome. So it was a Russian physician who in 18 from 1887 to 1889 who described this syndrome in alcoholics initially. But now we know that it's not only in alcoholics, but it can be there in other people as well. So it's not only alcoholics. And the prime deficiency, as we already discussed in Wernicke's encephalopathy, that the prime difficulty is in the thiamine deficiency, which causes amnesia. So basically, the thing which is responsible is amnesia. So cognitive impairment can be of different kinds. So cognitive impairment can be amnesic or non-amnesic or global. So here what we see is pure amnesic cognitive impairment. And that is why we cannot call it as like a type of dementia. What we classify is like a mild cognitive impairment of amnesic type. If we come through the DSM-5, which says mild neurocognitive disorder of amnesic type. And if we come through the uh, through the ICD-10, then it is amnesic syndrome. So it's a syndrome of polyneuritis, anterograde amnesia, and confabulations in subjects with chronic alcohol use. Can you please mute your mic for the time being, and when I ask something, you can unmute so that we don't have the background sound. Sergei Korsakov did not, however, differentiate between the acute stage of illness, which is Wernicke's encephalopathy, and which was kind of 20 years earlier by Karl Wernicke, and chronic memory impairment. So he described the second part, but he could not differentiate it well. So the differentiation between Wernicke's encephalopathy and Korsakoff syndrome was made by Karl Bonhoeffer in 20th century. So what are the symptoms of amnesic syndrome from ICD-10? So amnesic syndrome, ICD-10 is syndromic classification. It doesn't go with the cause. There is only like very few instances where ICD-10 determines the cause, and even there it is criticized that why they are talking about the cause. So uh, so for example, a subtype of autism is a kind of childhood disintegrative disorder. And then there is another syndrome of learning disability where they say that the person has, please mute your mic, please. Thank you. So the person who is having a kind of ringing kind of movements, uh, it is said that that their ICD-10 is describing causes. Similarly, ICD-10 to some extent it describes the causes when it comes to substance misuse. that because of alcohol, because of cannabinoids, so F10, F11, F12, F13 goes up to F15, 16. So it is all there. ICD-10 describes causes. Otherwise, it's a syndromic classification. So amnesic syndrome, amnesia, not agnosia, not apraxia, not aphasia, only amnesia, amnestic cognitive impairment, pure. That is amnesic syndrome. So memory impairment due to any cause. But here it is F10.6. So that means that it is because of alcohol, because if it is coming from F10.6, but it could be F11.6, F12.6, or it could be organic F0 something. So it could be any cause. So here, because it is F10, it is suggestive that here they are saying that alcohol is the most likely cause. Now we know that alcohol is, yes, but then there is an underlying or a secondary thiamine absorption deficiency, which is causing that amnesic syndrome in the end. And it is usually preceded by either full-blown Wernicke's encephalopathy or a subtle kind of Wernicke's encephalopathy. Wernicke's encephalopathy थोड़ी बहुत हो सकती है शुरू में, और ये जरूरी नहीं है कि full blown picture आए. It could be full blown picture or it may not be full blown picture. It could be subclinical picture of Wernicke's encephalopathy. Then it continues as Korsakoff syndrome. So memory impairment, it manifests in both. Number one, a defect of recent memory to a degree sufficient to interfere with daily living. So that is one thing. Disorder हम तभी कहते हैं when there is a deficiency, there is a defect in the day, interference in the daily living. Then we call it a disorder. Otherwise, we don't call it disorder. So defect of recent memory, anterograde memory. That is the most important thing. But then it's number two, which says the past, the retrograde memory and the long-term memory as well. A reduced ability to recall past experiences. So anterograde, like the short-term memory may be anterograde or retrograde. Short-term memory, anterograde is that I am giving you three things to remember. You tell me, and when you tell me back, that is the anterograde amnesia. If I can't tell, and if you ask the patient what did they eat in breakfast today, that is something retrograde but short term. So what happened 5 minutes ago, that is kind of short term but retrograde, and retrograde usually goes to long term memory. So there is a defect in both. It says and anterograde and retrograde, both type of amnesia should be there, although anterograde amnesia may be more prominent. Now, which I have lighted and highlighted as green, is absence of. So absence of a defect in immediate recall means I'm giving a green signal that immediate recall is normal. Consciousness is normal. There is no delirium. There is no clouding of consciousness. And number three, global intellectual decline. So there is no global intellectual decline. There is no dementia. So when it is pure anterograde and retrograde amnesia, which may also incorporate confabulation, and it interferes, that amnesia interferes with the daily living, That's what we call as amnesic syndrome. So the criterion A is the most important. The B is absence. So all other things should be normal. Now, no objective evidence on physical and neurological examination, laboratory tests of a disorder or disease of the brain, especially involving bilaterally diencephalic and medial temporal structures, other than the related to substance use, that can reasonably be presumed to be responsible for the clinical manifestations of described under A. So here they say that there should not be any evidence of physical neurological examination apart from what can substance use do. So what can you see? Now my question to the audience is, what can you see in the in the Korsakoff syndrome? What physical and neurological deficits you can see? Anyone?
Um, the gait disturbances can be seen, and fixed nerve palsy can also
Yes,
be seen.
exactly. Very good. Very good. Okay. So yeah, gait disturbances, cerebellar damage, and so other than that related to substance misuse. So if we just omit the last part of the this paragraph, we will say that there is no neurological deficit, but there is. So it is related to the substance misuse and related to alcohol use. There will be there, and that may be independent of Korsakoff syndrome. Even if the person is alcoholic, he did not develop Korsakoff syndrome, but even then, he may continue to have this thing going on, which is a kind of gait disturbances, cerebellar examination defects, or sometimes related to Korsakoff, cognitive disturbance may incorporate some frontal lobe damage as well. I will put it at the very last because it's not described in ICD-10, but now we know from the books that frontal lobe can also be involved to some extent. So mainly it is cerebellar, and maybe peripheral neuropathy may be there due to chronic alcohol use. But if it is pure thiamine deficiency, then it should not cause due to other, if it's pure thiamine deficiency due to other reasons, it should not cause cerebellar damage or polyneuropathy or frontal lobe changes. So for example, if somebody gets amnesic syndrome due to pure primary thiamine deficiency, dietary deficiency, for example, from anorexia nervosa, or for example, from bariatric surgery, and he has not ever touched alcohol, we can we can think that there should not be any neurological signs except due to other causes, but not due to thiamine deficiency. So symptoms, DSM-5. DSM-5 calls it mild neurocognitive disorder. And the diagnostic criteria is that, like, usually in mild neurocognitive disorder, you see attention, concentration difficulties, executive function difficulties, learning and memory, language, spatial cognition or special cognition, whatever it is. So we see disturbances in those. Uh, but here, so executive functioning, usually it is apraxia defines the executive functioning, and aphasia, here it is language, and agnosia is the spatial cognition, visuospatial cognition, it is agnosia. So instead of using those A's, we just see here, like we describe that as other terms. So here we see only deficit in learning and memory. Usually attention and concentration, like the working memory, should also be impaired in mild or major neurocognitive disorder means mild cognitive impairment or dementia. You should see some kind of attention deficit. But here in Korsakoff syndrome, there is no attention deficit. The only thing which is uh, which is affected is learning and memory, anterograde amnesia, and retrograde amnesia. The working memory, which is the attention and concentration, it is not disturbed. Okay. So now, based on the concern of the individual and knowledgeable informant and the clinician, there has been a mild decline in cognitive function and a modest impairment in cognitive performance, preferably documented by standard neuropsychological testing in absence of another quantified clinical assessment. And here they say that the cognitive deficits do not interfere too much with the capacity of independence in everyday living. So, in the past slide, we were saying that uh, sufficient to interfere with daily living. But here it contradicts the ICD-10 that it does not interfere the capacity of independence in everyday living. So if we just like trying to match both, that means that it does not significantly interfere with the capacity of independence in everyday living. So to some extent, they can still uh, live independently. However, they will have some difficulty. That's how we can correlate the ICD-10 and DSM-5. And they are not because of delirium, they are not because of the any other mental disorder. Confabulation. So confabulation is a thing which is seen mostly in Korsakoff syndrome. It can be seen in any mild cognitive impairment, it can be seen in dementia, but it is especially seen in Korsakoff syndrome. And confabulation is prominent in certain alcohol amnestic syndromes such as Wernicke-Korsakoff syndrome. So what I do is called I name it as a breakfast test. What did you eat in breakfast? आपने आज नाश्ते में क्या खाया? फिर 2-3 मिनट के बाद दोबारा पूछें. Ask again in 2 to 3 minutes. What did you eat in breakfast? Usually they say I had uh, piece of bread, jam, and butter. But the next, after you ask in 2 or 3 minutes, they may say, I ate cereals. Or if it is Pakistan, they may say that anda paratha khaya. But 5 minutes ago, they may say that I ate halwa puri. So that confabulation can be there and can be seen in this Wernicke's Korsakoff syndrome, especially like the Korsakoff syndrome we are talking about. Orientation, again, because of amnesia, orientation may be disturbed, but it's not visual spatial recognition. They can recognize their house, but they may not remember the house number, and they may have to learn it again, and they may learn it again. So orientation, so they may not know the exact date, but overall they know what's going on. So so there could be some orientation difficulty in time and place and person due to amnesia only, not due to visuospatial agnosia. Have you met me before? Again, they may confabulate. They know that their memory is not the best and they're trying to cover it up. So they say, oh, yes, I met you, because you are tricking them. You're tricking them that we have met before. So if you're tricking them, they may come under the trick and they may say, oh, I have to prove that I'm sharp enough. अब याद तो उनको है नहीं. So they will just say, oh yes, I met you before. So ये confabulation का एक तरीका है. Orientation में से भी confabulation निकाली जा सकती है. What is the date today? Well, he may say 21st of March, 2016. After now, it's the wrong answer. If they gave the accurate answer, then that means that they know. But first time they said 21st March 2016. You ask again after 2 or 3 minutes, they may say, well, it is 16th October 2006. So they may give different answers, and that will tell you confabulation. Even when they are saying 21st of March 2016, that is showing confabulation. But if you can confirm that in a clinical examination setting by asking that again, uh, and creating inconsistencies. So now this happens without the person being aware of it. That is confabulation. Otherwise, it could be something deliberate. So it's not even deliberate. They may not even remember what they said 5 minutes ago, and that's why they are just saying. So we cannot blame them for this because it is happening due to a neurocognitive impairment. Now, confabulations are characterized into two types, provoked and spontaneous. So provoked confabulation जो होगी वो ये होगी कि you ask a specific question, what did you eat in breakfast? And they will say, I ate halwa puri or I ate the anda paratha. And that is provoked confabulation. Spontaneous confabulation is less common. Spontaneous confabulation means that they will start telling you stories, and there could be something wrong, something made up in those stories, fabricated story without any obvious motivation or provocation. So if they are telling, that's why collateral history is so much important. So if the wife of the person is uh, sitting there, or or the spouse, so she will tell you that yes, he is telling a story which is right, but there are certain things which are totally wrong. He says that we stayed in Mehran Hotel in Murray. It was not Mehran Hotel, it was Cecil Hotel, or it was Punjab Hotel. Then he says that we took a chairlift, which is not right. We never ever took chairlift together in our life. So these are the certain things, spontaneous confabulation. They will be picked up by the collateral history. Is it clear so far?
Yes, sir.
Okay. Now, anterograde versus retrograde memory. As I told you earlier, when you ask something,
Sir, I have a question, please.
please, is it Darshad?
Right, सर थैंक यू वेरी मच फॉर योर टाइम। और इसमें एक सवाल मेरे जहन में आया था
जी जरा
कि हम
बताइए।
डिफरेंशिएट कैसे करेंगे कि ये जो इंडिविजुअल है जो अल्कोहल अब्यूज करता है और प्रॉब्ली इयर्स से कर रहा है, तो ये वैसे हमारे साथ लाई कर रहा है या कन्फेबुलेट कर रहा है?
अच्छा, इसमें it is very difficult because sometimes that can happen in the clinical settings, that a person has come and is kind of making up things, and there could be an element of dissociative amnesia involved in it at times. So it is very difficult to describe, but if you see that how many inconsistencies they are there in his account, अगर और उसका कोई आगे कोई उसका कोई गेन है, कोई उसका पर्पस है जिसकी वजह से वो झूठ बोल रहा है, For example, if someone has murdered somebody and he is an alcoholic and he is taking, so we are in difficult position as psychiatrists. So we can just say that he says that he does not remember. All you have to do is you do, for example, Montreal Cognitive Assessment again and again, MOCA test, or you do the Addenbrook's cognitive examination, you do other tests, and and then you see the inconsistencies between the daily tests and different examiners, and also ask about if the patient is admitted in the ward, then ask about the ward nurses, how they are getting on when watching telly, or do they think that his memory is perfect at other times and he malingers only at when the doctor comes. So you take collateral history from different sources, and that will confirm you that yes, it is something going on. Sometimes there could be an improvement you can see. So when in doubt, if you are really, really in doubt, then you may give some benefit of doubt to the patient, but only some benefit of doubt, especially in the medico legal cases. You cannot say that it is 100% malingering. You cannot say that it is 100% Korsakoff syndrome. And even if you say yes, it is Korsakoff syndrome, but it is up to the court to decide whether he has done something or not. So we can only give our opinion. So we cannot say whether at the time of uh, whether he did the crime or not. He may have done the crime. We don't know. So usually, by default, we give the benefit of doubt to the patient, and usually we say that yes, it is an amnesic syndrome, and that will tell you, if you just measure the confabulation and different answers at different times, you will just judge it yourself. So it will be your clinical judgment, and maybe get an expert opinion from your colleagues. What do they say? So take a second opinion. If you are an SHO or a medical officer, ask your senior registrar. If your senior registrar, ask your consultant. So, or ask a neurologist, what do they say? And get some information from the MRI brain. It is very important. If there are structural changes, then maybe it's most likely that the patient is telling right, that he has Korsakoff. But for example, if the mammillary bodies are damaged, or if there is some thalamic damage in the MRI brain, or if there is a cortical brain atrophy, then there are changes. Then assess for other neurological signs, and cerebellar examination. So globally, you can have an idea that if the person is lying or it is truly confabulating. Okay, anterograde and retrograde memory.
Thank you, sir.
You're welcome. So retrograde amnesia is kind of less severe, and anterograde is more. But when you try, retrograde is that what did you eat in breakfast? That's retrograde. When you got married, that's remote long-term memory. That's also retrograde. Anterograde is you tell them to register a 7-item name and address, and then you ask that again in 5 minutes, and if they can recall, that's fine. But immediately they should be able to tell the 7-item registration recall. If they cannot even tell immediately, that means that either there is, I mean, then most likely it is mild cognitive impairment more than the amnestic type, because attention and concentration is also being disturbed. Because here the A, complex attention, that should not be disturbed in Korsakoff syndrome. Or if there could be pseudo dementia or whatever you were saying, that if the patient is making up or something. These we usually keep the malingering things at the back of mind, but it's last of our diagnosis. So, so Individuals with Korsakoff syndrome classically present with confabulation, which is explained by most experts as attempts to cover the memory deficit. And neuroimaging tests are helpful to differentiate between several causes of amnestic syndrome. Mammillary bodies atrophy in Korsakoff syndrome, strategic localized strokes, anoxic lesions of hippocampal structures, and T2 weighted hyperintensities in bilateral temporal poles in herpes encephalitis, etc., etc. Now here there is a differentiating point. So if we compare the amnesia with Korsakoff syndrome, amnesia delayed recall is there. Yes, Korsakoff, the recall is delayed. Dementia rating scale you आप उसमें memory index पे, for example Addenbrook's cognitive examination आप जरूर करें. You must do Addenbrook's on these cases because you can see the memory, differentiate memory. It has subset of memory. So kindly mute your mic. So dementia rating say memory index. That means that you can see something in the memory subdivision, subscale in both amnesia and Korsakoff syndrome. Now, dementia rating scale uh, initiation and perseveration index. In Korsakoff syndrome, you can see some frontal lobe signs, which is not there in ICD-10 or DSM-5, but the latest edition of uh, Kaplan and Sadok textbook is showing that there could be some frontal lobe changes. So it is amnesia plus frontal lobe damage in Korsakoff syndrome, because Wisconsin card sorting test, that is an executive functioning test, and that is also frontal lobe. So you can see something, perseveration, एक ही बात बार बार कहना, and Wisconsin, and difficulty in initiating things, and Wisconsin card sorting tests. So executive function difficulties can be there in Korsakoff syndrome. Meta memory. Meta memory is the insight into memory difficulties. Now, temporal order memory, yes, they can be in amnesic syndrome, and it's more pronounced in Korsakoff syndrome. So there could be more kind of retrograde deficits, maybe more pronounced, or there could be temporal order memory should be there, that they're not aware of the time, that which thing was first, which came after, पहले क्या हुआ फिर उसके बाद क्या हुआ, they may not know the order. Meta memory, insight into the memory. Amnesic, if it is pure amnesia, then patient may have some insight that their memory is defected. But here, because the frontal lobe is also involved, then you will say that meta memory, that insight into the memory deficit is involved, so it's lost, and therefore you can see confabulation. Release from proactive interference. So again, it relates to the insight, and so amnesia, you don't see that, and you can see that release from the proactive interference. Now, if it is a pure frontal lobe damage without Korsakoff syndrome, then you don't see memory disturbances. Memory index should be normal in pure frontal lobe syndrome. But here, but they will do things, perseveration and difficulties in initiation, Wisconsin card sorting tests. there will be temporal order memory will be kind of defective here, and insight into memory difficulties or cognitive difficulties will be lost. So it is this Korsakoff syndrome. Here you can see all the signs of frontal lobe difficulty and amnesic difficulty are there. So it's a mixture of frontal lobe damage and amnesia. And even if we draw a circle and overlap these circles, so here there is overlap. So we can even make circles here in this diagram, and the overlapping part will be Korsakoff syndrome. So it carries frontal lobe damage and amnesia, and I was like in the last few months I was kind of surprised that there were clear frontal lobe signs in the patients with Korsakoff syndrome we were seeing. So we should keep it in mind. Okay, and now assessment of Korsakoff syndrome, history and collateral history. So important, collateral history, mental state examination, mini mental state examination, MOCA, Addenbrooke's ACE3, or you can do ACE2R, which is a previous version, but that contains MMSC, which is now uh, copyrighted. So you have to have the copyright to use MMSC, or either using MMSC or using the ACE2. So so ACE3, you can do frontal lobe examination, frontal assessment battery, and cerebellar examination. So cerebellar examination, you can see kind of because of alcohol there could be deficits in there. And
डिमेंशिया फ्यूजन हो सकता है क्या सर डिमेंशिया के साथ?
दोबारा बताइए.
डिमेंशिया अल्कोहल रिलेटेड डिमेंशिया के साथ भी इसका कंफ्यूजन हो सकता है ना सर?
Exactly, that is a very important differential diagnosis. And even now the last slide puts me into kind of the doubt that even if the Korsakoff syndrome is primary because of pure thiamine deficiency, can we still see the frontal lobe damage and frontal lobe signs? I would say yes. So it's not necessarily due to alcohol. So we can still see some frontal lobe damage, but no, we won't see cerebellar because cerebellar is not a symptom of Korsakoff itself, but the frontal lobe syndrome can be present in Korsakoff syndrome, and in my opinion, due to any etiology, Korsakoff syndrome may have frontal lobe damage. When it comes to cerebellar damage, that's an additional thing which is directly due to alcohol. And yes, it may progress to alcohol-related dementia in future, especially if you see the vascular changes, lacunar infarcts, or if you see the cerebral atrophy, then the patient is more at high risk of developing alcohol-related dementia. Of course, the differentiating point will be presence of agnosia, aphasia, and apraxia in dementia, and absence of these things in Korsakoff, and preservation of the working memory in Korsakoff syndrome, which is attention and concentration is preserved in Korsakoff syndrome, but there could still be some like the frontal lobe symptoms there. So cerebellar examination, yes, you should do, because a broad-based gate will tell you whether there's a there's a cerebellar damage or not. Imaging MRI brain and establishing confabulation, anterograde versus retrograde amnesia, check for working memory, short-term memory, long-term memory, and when you're that's how we'll do. Pathophysiology we have already done when we were doing the Wernicke's encephalopathy, differential pathology, diencephalic damage like the thalamic damage, degeneration of mammillary bodies, and confabulations are more frequent in diencephalic amnesia. So if there are confabulations, that means that the deep brain, the thalamic part, is more affected, and then and it develops as a sequel of a Wernicke's encephalopathy. Kraepelin distinguished between alcohol-related Korsakoff and Korsakoff related to non-alcoholic process. And the last picture just says Korsakoff. It just that usually alcoholic Korsakoff syndrome. So you can still see some frontal lobe pathology in Korsakoff syndrome. Primary thyroid deficiency, it can happen due to malnutrition, eating disorder, and secondary could be due to alcoholic use disorders. Serotonin metabolism is also influenced, so it's worth checking the mood of the patient. They may go into depression if there is a 5-hydroxytryptamine or serotonin deficiency, and sometimes CSF levels of 5-HIAA are deficient if you do the lumbar puncture and CSF examination, which should not routinely be done, but sometimes if you are doing for other things, you can check the 5-HIAA levels if they're done in your country. We have never done, by the way. So lesions in medial dorsal thalamic nuclei, mammillary bodies, fornix, cerebellum, and anterior thalamic nucleus. So mammillary bodies atrophy you see typically in Korsakoff syndrome. Differential diagnosis, delirium, which is kind of Wernicke's encephalopathy, or cognitive impairment, dementia, semantic memory, language, and praxis. So even here, semantic memory may be preserved, but if it is so much disturbed, it can be disturbed as well. But usually it should be preserved in Korsakoff syndrome. Psychogenic amnesia can be differentiated. That's your question, whosoever asked earlier on. So psychogenic amnesia can be differentiated by its presentation, onset after traumatic event, no evidence of substance or general medical condition. Amnesia for personal identity, which is conserved in amnestic disorder for a circumscribed event, but preserved memory for the and preserved ability of learning and its course, abrupt onset and resolution, no residual impairment. So basically psychogenic amnesia, you can see a psychological event just before it developed, and absence of Wernicke's encephalopathy, or even अगर आपको मिलती भी है Wernicke's encephalopathy, तो maybe one symptom may be enough. It could be very light, could be just delirium tremens, and then it may kind of progress into Korsakoff because you missed the others. You might have missed the 1 or 2 symptoms. So, but it can still progress into Korsakoff. लेकिन अगर कोई ऐसी बात हुई ही नहीं है और कोई psychological कोई event, it's very, then can you can think of psychogenic amnesia or dissociative amnesia. Because if then, for example, if the MRI brain, everything is clear and collateral history is also not suggestive, and the ward nurses are saying that the person is fine, then you can differentiate the psychogenic amnesia, because psychogenic amnesia will have an abrupt onset and resolution, and no residual impairment will be there. But जो Korsakoff syndrome है उसकी it will continue for a long time and it will be there in all settings. Psychogenic amnesia, yes, it can present, but it should be usually like short term. It could be for for a circumscribed event or for only some things, उसको कुछ चीजों की याद नहीं है, बाकी हो सकता है उसे सारी चीजें याद हो साइकोजेनिक एमनीजिया में. Korsakoff syndrome is more kind of global amnesia. Not saying global cognitive impairment, but global amnesia. So that means कि उसको कोई भी चीज याद नहीं रहती, लेकिन जो डिसोसिएटिव एमनीजिया वाला पर्सन है उसको सिर्फ उस इवेंट से रिलेटेड चीजें याद नहीं रहेंगी, बाकी चीज, एंड यू कैन से इट्स डिसोसिएटिव एमनीजिया एंड इट्स अब्रप्ट ऑनसेट एंड यूजुअली abrupt resolution as well with no residual impairment. जिस तरह से ड्रामों और फिल्मों में देखा जाता है, you see in dramas and films that one of the actors, one of the characters, they lose their memory and it suddenly comes back. That is kind of psychogenic or dissociative amnesia. Course and prognosis. About 25% of patients with Korsakoff syndrome recover. So you cannot say that it is totally irreversible. And that's why we saw a person in the last 2 months and that person recovered to some extent. Even then, we are giving him the benefit of doubt. Whatever he may or may not or to decide, we don't know, but what we can say that yes, he had some memory difficulties because it is seen by the ward staff, it is seen, it's manifested in the ACE3 cognitive test, it manifested in OCA, he confabulates a lot, and there is a kind of global kind of amnesia is there, and then he partially recovered as well. So now whatever the court wants to decide, it's up to them. So about 25% of patients may recover. The rest continue to suffer from various degrees of memory impairment. A significant minority needs permanent placement, and most amnesic syndrome may have a stable course. So that proves a significant minority needing permanent placement, because so that means that ICD-10 are right that it may suffer. That's why it is called disorder, that it may kind of have some degree of impairment in their day-to-day functioning due to memory impairment. If the memory impairment is so severe, yes, it will impair their with their day-to-day functioning. And if the memory impairment is just very subtle, then it may not. Other differential diagnosis could be post-ECT amnesia, and then so they can recover from amnesic syndrome, not from, we won't call it Korsakoff, but we'll call it
Hey, Dad.
Amnesia, or improve transient global amnesia, and then it can recover, or amnesic disorder secondary to traumatic brain injury.
Would you like some orange?
Thank you. So, and then thiamine, 1 to 2 gram daily, is likely to partially or completely reverse Wernicke's encephalopathy. But we don't know if it can reverse Korsakoff syndrome or not. Especially get the MRI brain. If the mammillary bodies are damaged, if there are damages in thalamus, then it's most likely not recoverable. But still, we can hope for the best. But thiamine may not be very helpful. We can give thiamine to prevent further damage. Then, unlicensed use of donepezil, rivastigmine, memantine. There are court case reports, but no controlled studies, and it's not licensed. Means that the country's national formulary does not say the indication of these drugs in Korsakoff syndrome. And then for the other types of amnesic syndrome, treatment is tailored according to the etiology. Acyclovir, अगर तो herpes simplex की वजह से हो रहा है, so you can see, you can give antiviral agents, for example, acyclovir, and then cognitive rehabilitation programs can help improve the patient's level of functioning. So, so cognitive rehabilitation, yes, that can make a difference. That will be the most effective treatment strategy. But unfortunately, so far, none have indicated benefits regarding the restoring or improving memory in the impaired domain. Now, we stop here and we stop the recording, and then